Well, welcome everyone. We are so excited to have you joining us today. We've got some really great information to share and some wonderful presenters as well. So before we begin, Kaylee, if you can hit that next slide for me. I'd like to note that the views expressed in written conference materials or publications and by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsements by the U.S. government. Next slide, please. My name is Mackenzie Simmons, and I have the privilege of serving as the project manager for SAMHSA's 988 Crisis Systems Response Training and Technical Assistance Center that's operated by Altarum. Now, we wanted to take a moment to ensure that everyone in the audience is ready and comfortable with the technical aspects of this webinar. So I'll now turn things over to my colleague, Kaylee, to walk you through the webinar interface, including how to submit questions and other technical information.
Thank you, Mackenzie. As you will see, closed captioning is enabled for today's webinar. If you do not see closed captioning going across the bottom of your screen, please go to the three ellipses and click on that and click on closed captioning, and that will turn it on for you. If you do need technical support during today's webinar, please reach out using the Q&A function, and I will address it for you. Lastly, if you have any questions for our presenters during the presentations, please enter them into the Q&A area, and we will address them as time allows after the presentation during office hours.
Thanks, Kaylee. Next slide, please. So today's webinar is the fourth session of 6 in a series of webinars called Connecting to Serve, Promising Practices for 988 and 911 Collaboration. The fourth session in this series intends to explore the recently released report, The Road to 988 and 911 Interoperability, and discuss the lessons on 988 and 911 interoperability. The goal of this webinar is to examine various ways in which diverse states around the country organize and coordinate with partners to deliver comprehensive crisis care. The writer of the report, Dr. Stephanie Brooks Holliday with RAND, will highlight different approaches to interoperability, the various factors that contribute to facilitating systems coordination, identify components that hinder progress, and additional elements to consider that support alignment between 988 and 911. After attending this webinar, attendees should be able to review various communities' 988 systems approach collaboration with 911, explore factors that aid interoperability, as well as barriers and considerations to deliver an equitable approach to 988, and finally, review the findings from the research brief, Lessons on 988 and 911 Interoperability. Next slide, please. Before we start our presentation portion, I'd like to introduce Tiffany Russell. Tiffany serves as the Chief of Crisis and Justice Initiatives with SAMHSA's 988 and Behavioral Health Crisis Coordinating Office, is an advisor to the 988 Director and other members of SAMHSA's senior leadership in planning and determining policy, programs, and activities that address complex challenges in coordination of 988 crisis centers with law enforcement, 911 call centers, and emergency medical service providers. She also develops, recommends, and implements programs and provisions of guidance related to improving crisis response and equitable access to services for individuals with behavioral health needs that minimize unnecessarily law enforcement involvement and promotes diversion from the justice system. At this time, I will hand things over to her for a brief welcome and to introduce our guest speakers.
Thank you so much, Mackenzie, and good afternoon to everyone. We are so excited to have you join us and are thrilled to have your participation. Before we move forward with introducing our speakers, I want to thank SAMHSA's leadership for the continued support of this initiative and the transformation of the behavioral health crisis system. Thank you to Assistant Secretary Dr. Miriam Delphin-Rittman and her executive leadership team, the Director of 988 and Behavioral Health Crisis Coordinating Office, Monica Johnson, Deputy Director John Palmieri, Division Directors James Wright and Jill Mays, and Senior Advisor Dr. Richard McKeon, as well as each member of the 988 team. I also want to thank NHTSA and the National 911 Office, as well as Vibrant Emotional Health, for their partnership in developing this series. This webinar series is just the first of many more opportunities to engage with the 988 team and Crisis Response Training and Technical Assistance Center. More information on how to access these opportunities will be provided by Mackenzie and the rest of her team a little later in the session. Finally, as the federal lead organization of the 988 Suicide and Crisis Lifeline, as well as Behavioral Health Crisis Services Transformation, it is our mission to ensure that every person has someone to call, someone to respond, and a safe place for help when experiencing a behavioral health crisis. Our office is working tirelessly to provide support, guidance, and technical assistance to states, jurisdictions, and territories to ensure people across the United States have access to the crisis care they need at their most vulnerable time. Now, let's get to the introductions of our guests today. Today, I am joined by a panel of subject matter experts within the field, and we'll take a moment to introduce them now. Our first guest is Dr. Stephanie Brooks Holliday. She is a clinical psychologist and senior behavioral health scientist at RAND. Her work focuses on the intersection of behavioral health and the legal system, including opportunities to divert people away from the formal legal system involvement. She recently led a study, which we will learn more about today, focused on different models of 988 and 911 interoperability funded by the Pew Charitable Trust. Her other research has focused on diversion, alternatives to incarceration, and reentry, especially for individuals with behavioral health concerns. Joining her is Commissioner Darcy Miller, a licensed clinical social worker and also the commissioner of the Orange County Department of Social Services and the Orange County Department of Mental Health, a position to which she was appointed in October 2016. As commissioner, Ms. Miller oversees Orange County's planning, development, and coordination of services of a wide range of social welfare programs under the divisions of human services, economic independence, mental health, developmental disabilities, and chemical dependency. Nearly 10,000 Orange County residents with a mental illness, developmental disability, or substance abuse problems are served by the Department of Mental Health each day. The department coordinates programs with numerous private and not-for-profit partners in the county. Commissioner Miller is passionate about infusing the system of care with trauma-informed, culturally competent, and recovery-oriented values and practices. And rounding out our guest today is Lacey Trimble. She started her social work career in a county-operated school-based mental health clinic in South Carolina. She moved back to Orange County in 2007 and worked in private practice before returning to county service when she was hired as a staff social worker for the Orange County Department of Mental Health outpatient clinic in 2009. Lacey became the director of the Port Jervis Mental Health Clinic in 2010. Lacey was then promoted to the Director of Mental Health Program Service in 2016 and became a part of the local government unit, allowing her to expand her role beyond the county-operated clinics. In this role, Lacey assisted with completing a grant application to the New York State Office of Mental Health Partnership Innovation for older adults, and Orange County was subsequently awarded the funding. The grant led to the creation of the Welcome Orange Geriatric Initiative, which provides older adults who have mental health, substance use, and/or aging needs with community-based services. With that, we will kick things off with Dr. Holliday to get us started.
All right, thank you so much for having me here today. And thank you so much to my partners from Orange County for joining us. We're really excited to share findings from this recent report and to really feature the hard work that their community and these other communities have been doing to support 988 and 911 collaboration. Next slide, please. So I want to start by giving you an overview of what exactly this project was and what we set out to accomplish with it. So as was mentioned, this is a project that was funded by Pew Charitable Trusts, and our overarching purpose was to be able to document some different models of 988 and 911 interoperability, really with the goal of serving as a roadmap to other jurisdictions that might be interested in achieving interoperability but not know where to start, or that might be already starting the process but running into some obstacles. And in particular, we had 3 goals that we were hoping to accomplish. So first, we wanted to document different models and present a detailed description of the nuts and bolts of how interoperability works in each of the sites. We also wanted to document the obstacles that were encountered during planning, but also what helped the planning process go more smoothly, and then document some of those lessons learned from planning and implementation to serve as kind of a roadmap of sorts to those who are looking to begin doing this themselves. Next slide. So I'll tell you just a little bit about how we went about selecting the sites that we worked with and a little bit about our methods, but I mostly want to save the bulk of the information for what we found and how this might be of value to other jurisdictions. So just to say a little word about how we got to the 3 sites we worked with. We were working alongside the National Association of Counties. They were doing a related project where they were spotlighting innovations related to 911 and behavioral health. And based on some of their own network and research, they had identified an initial set of 13 candidate sites. Then our team had a set of 11 different things that we were hoping to get some variation with by selecting sites that we didn't have, for example, just 3 coastal urban sites that were really well resourced with large populations. And in particular, we were trying to get some variation with respect to the model of interoperability. We wanted to highlight a couple of different options with respect to population density and urbanicity of the site, and also with how recently interoperability had been established. We wanted to make sure to include a couple of sites that had been in the process of interoperability for a while, but also one that was fairly recent to interoperability so that planning and the processes of that might be especially fresh in their minds. Next slide. So here's a brief introduction to each of our case study sites. The first was Minnehaha County and the city of Sioux Falls in South Dakota. And as you'll see on this slide, we did accomplish some variation with respect to population and also the way that 988 and 911 are organized within the city, the county, the state. So in South Dakota, they have a single 988 call center for the state. It's based out of Sioux Falls in Minnehaha County. And they have 33 PSAPs, or public safety answering points, statewide, including some tribal PSAPs. South Dakota is home to 9 federally recognized tribes. So with this case study, we particularly focused on the relationship between the 988 call center and the PSAP that was located in Sioux Falls. They have a particularly strong relationship, but also learned a bit more about how they're continuing to roll out partnerships with PSAPs across the state. Our second site was Orange County, New York. You'll learn a lot more about how this operates directly from them. But here we have 988 operated out of a countywide call center that also answers for their local hotline, which has existed in their community for a long time. Then their 911 call center is a county PSAP. And the thing that is so interesting about Orange County's model is that they are co-located. So their 988 call center and their local hotline is operating out of the county PSAP. And then our final site was Fairfax County, Virginia. So they have a 988 call center that regionally serves Northern Virginia. And then they have a primary PSAP at the county level, but then within Fairfax County, there are some cities and towns that have their own PSAP that serve as secondary PSAPs. Next slide. So once we selected each site, we used a few different methods to do our deep dive into the models that are being used. So we did interviews, we did a review of relevant documents like policies and protocols and training materials, and we spent a couple of days on site. The specific people we interviewed varied from site to site, but included 911 leadership and dispatchers, 988 leadership and staff, mental health, law enforcement, co-response teams, mobile crisis teams, advocacy groups, community organizations, peer support, really anyone who had a role in the planning and implementation of interoperability. And you can see the areas that we discussed here. I'll kind of skip over much of the in-depth detail of the methods, but always happy to answer that at a later time. Next slide. And so with our analysis and with what you'll see presented today, we had kind of two stages that we were looking to do. The first stage was really about the development of process maps so that we could document in detail the way collaboration between 988 and 911 happens. We wanted to show the role of each agency, the points of interagency communication, the decision points, and I'll show you those in more detail in a couple of slides. But then we also wanted to get a broader sense of some of these themes, like what are the training and quality assurance approaches? What did the people at each site say were really the facilitators of planning? What were the lessons that they learned along the way? So we did a deep dive into that with each site. But then what I want to share with you today are some of those findings that arose from each site, but also some of the things that came up across sites that might serve as a guide. Next slide. And so in a moment, I will dive into some of the findings, but I wanted to first just highlight some of the ways that I hope that this report can be of value to jurisdictions who have started the planning process, are hoping to start the planning process, or even have planning and implementation underway, and are looking for some additional guidance. So I think one of the key advantages of this document is that it allows you to see these three different models of interoperability, what those different decision points are, the different protocols, the different definitions. And we're not the first document to do this. The National Association of State Mental Health Program Directors put out a playbook a couple of years ago that also depicts a handful of local examples, but I kind of feel like the more examples you can see, the better, especially if you can look at the local characteristics and say, oh, this kind of lines up with us in terms of population size or the way their PSAP and 988 call centers are organized, and maybe see yourself in some of these examples. Relatedly, this report will show you how some of the local resources and characteristics of each site shaped the model that they use. For example, policies related to the dispatch of mobile crisis or the availability of different types of mobile crisis teams. And I'll show you what I mean by that in a few slides. Then I also want to have this report serve as a way to identify kind of what the ingredients are to successful planning and implementation, and also be able to anticipate some of the speed bumps that you might encounter along the way. Because anytime that you're doing something this innovative, it's impossible to implement it. There's so many stakeholders, there's so many decisions to be made. To implement it without speed bumps is just unrealistic. But what we wanted to do was be able to document those and then give a sense of how each site tackled those obstacles so that you might know what to anticipate or even be able to avoid some of those obstacles by planning for them in advance. Next slide. And so with that, I'll switch gears to actually share with you some of the findings from the report, beginning with the process maps. Next slide. So for each of the three sites, we developed a process map modeling out those decision points and pathways that might be followed when a call comes in about a person who's having a behavioral health emergency in the community. And so the purpose of this particular slide is not to overwhelm you or to expect you to be able to see details of each of the three maps, but rather to give you a sense of the fact that we tried to create a pretty parallel structure for showing the process across each site. And I think that this is helpful because it shows you where there are some points of similarity in the process and flow, but also where there are places of departure and where it is local decisions and policies and resources that did shape the way that the flow occurs and the decision points that have been built in. Next slide. But what I will do is walk you through one of these examples in more depth so that you could see how you might use the information if you're planning or implementing. And the map itself, which is what I mostly show on these next several slides, is one part of the information, but in the text of the report, you'll also find a lot more detail about what's happening at each of these stages, because there's a lot that the process map cannot show you. What are the specific questions being asked? Is there a structured protocol? Is there flexibility in how the questions are asked? When they transfer the call, is the person in a three-way call? Are they patched in? Are they put on hold? All of those really important details. So I'll walk you through the map for this site. This is from Sioux Falls, and talk a little bit about the details behind each of the decision points. All right, next slide. So we will start with a person who is experiencing a behavioral health crisis in the community. And so we'll assume that this is a person who called 911 as their first point. So the PSAP in this community uses emergency dispatch protocols that were developed by the International Academies of Emergency Dispatch. So the call comes in. After getting the caller name and location and determining that it's behavioral health related, the 911 call taker is using that behavioral health EMD protocol to ask a very structured set of questions. And the responses to each question are recorded in their computerized system, which integrates with their CAD system, their computer-aided dispatch system. And depending on the caller's set of responses to the questions, the system then tells them that this is the type of response the caller should receive. Now, early in interoperability at this site, there was kind of a narrow set of calls that could be transferred to 988. But then in 2023, that EMD protocol was updated, and there are now more nuanced questions to try and disentangle cases of suicidal ideation versus suicidal intent. And that's also led to more scenarios in which a call can be transferred to 988. So at this first stage, the person is trying to determine, is this a person who is experiencing suicidal ideation or intent? Is there opportunity? Is there means? Is the person alert? Next slide. And if the answer to this is no, the person is maybe actively intending suicide, or is experiencing a medical emergency, or sorry, is actively intending suicide, or maybe they're not alert, then the next thing that the person has to determine is whether there's a medical emergency. Is there a suicide attempt in progress or an overdose in progress? Next slide. If yes, then they send law enforcement, EMS, fire, depending on the specific circumstances. Next slide. But if not, then they send law enforcement. Next slide. But let's go back up to that first question. Let's say we have a person who is in crisis, but they are not actively suicidal, or they may have suicidal ideation, but not means or opportunity or specific intent. In this case, we have a potential candidate for a transfer to 988, but sometimes in those circumstances, the caller wants law enforcement to come out anyway. Maybe it's a third party calling, or maybe it's someone who just feels more comfortable with law enforcement. And so if the caller requests law enforcement, as you see, then they do send law enforcement. Next slide. But if the caller is not requesting law enforcement, then it can be transferred to 988. And there are multiple ways that the call can be transferred. So sometimes the 911 call taker puts the caller on hold, calls 988, gives some basic information about the caller, and then joins the calls together. Other times the caller's on the line the whole time while the transfer is made, and so details shared by the 911 call taker are heard by the caller as well. And the 988 call center has programmed a direct number so that PSAPs can just do like a one-button transfer when it is going over to 988. They don't have to dial the number separately. And it also means that on the 988 side, they can see that the call was transferred from 911. Now at that stage, the 988 call taker does have a little bit more information about the caller than they would if it was just coming in directly to 988, but it's still just the bare bones. So at this stage, they're picking up with their typical role. They're assessing current level of risk. They're trying to get a sense of risk and protective factors. Next slide. And in the vast majority of cases, they find that the caller's needs can be addressed on the phone more than 95% of the time. I think the numbers are actually more than 97% of the time in that community. Next slide. But once in a very rare while, the 988 call taker is working with the caller, trying to safety plan, trying to work towards stability, but things continue to escalate. And if there is a concern about safety, then the 988 call taker can transfer back to 911 to request dispatch. And if that happens, the 911 call taker does not have to redo the behavioral health EMD protocol. They can just dispatch right away. Next slide. So that just gives you a sense of some of the detail that gets documented within the report, and you can kind of do a deep dive into each site and get a sense of what are their questions, what are their approaches, what are their transfer protocols like. Another way, though, that you can use these process maps is to see how some of the differences in local resources do shape the process and the protocol. So let me highlight an example of that. Next slide. So let's zoom in on mobile crisis at 2 of the sites. You'll see I'm very studiously not presenting examples from Orange County since we have them here. So we'll first zoom in at Sioux Falls. So here, mobile crisis falls under kind of the 911 side of the process map. And that's because in South Dakota, state policy has kind of resulted in mobile crisis just being dispatched by law enforcement. So what happens is law enforcement will be on the scene, and if someone seems like they meet criteria for a psychiatric hold, that's the point at which they call mobile crisis. Their mobile crisis is on call 24/7 and operated by their local community mental health center. Next slide. But then we can look over on the third map, which is Fairfax. So it looks different in Fairfax, and in part this is because they have two different mobile crisis options. So one is their regional mobile crisis team. This is a resource that can be sent out by their 988 call center if someone is pretty much stabilized, but still could use some additional support with something like safety planning, or they just feel like they could use in-person support, not just the telephone support. Then they have a regional mobile team that can be dispatched. And importantly, this is voluntary. So the caller has to agree that they want the mobile team to come out. Slide. But they also have a second team, which is operated by their behavioral health authority. It's a mobile crisis unit, and they can be called out straight from the PSAP, but more often in practice, they're called out once, for example, law enforcement is on the scene. They're available in more limited number of hours, but they're also able to go out to more acute scenarios. For example, when there's suspicion that someone might need a higher level of care, like a psychiatric hold. So that just gives you a sense of how these maps can show you the ways in which different resources might shape the way that a community has decided to implement not just interoperability, but the use of, or where exactly this plugs into their overall crisis continuum. Next slide. Okay, so shifting away from talking about the process maps, I also want to dive into some of the lessons that were learned from planning and implementation. And I won't be able to go into full detail about everything that we learned, but want to give a sense of some of the things that might be most valuable to those who are currently doing this work right now. Next slide. So one topic we asked at each of our sites was whether there were groups within each community that experienced particular challenges, either engaging with the crisis continuum or maybe had additional needs that weren't quite so easily met by the kind of quote unquote standard crisis continuum, and how they had solved that. So here are two examples. In Sioux Falls, people talked about how there are a lot of different refugee communities, and there's more than 137 languages that are spoken. And so they talked to us about some of the ways that they've tried to overcome some of the kind of structural and language-related barriers, but also things like stigma against help seeking. So their 988 call center has partnered directly with refugee service organizations. They've gone in and made connections with their multicultural center and community gathering places. When language is a barrier, both 988 and 911 have been able to use Language Line, which is a translation service, and this has helped them to make more inroads with these communities. In Orange County and Fairfax, another population that came up were frequent utilizers of emergency and behavioral health services. And in both places, we learned about the approaches that they use to bringing together multidisciplinary teams on a regular basis to identify these folks, dig into what their needs are, see what needs maybe are and aren't being met, and then figuring out ways to leverage other local resources to plug in the gaps, and hopefully then decrease the amount that these folks are utilizing the emergency services because they've been collected with a more stable source of services. Next slide. We also wanted to understand the facilitators of planning and implementation of interoperability. I like to think of these as the ingredients to success at each of the sites. So here you see kind of the full range of factors that emerged across sites through all of our interviews and we document review and site visits, but I also want to highlight a couple of these for you all and how exactly they did serve as facilitators. Next slide. So clear policies and protocols. Things that govern the transfer process, things that govern the decision points, this was found to be really valuable. People told us that having these types of clear policies and protocols can make call takers feel more comfortable with their role, but also knowing what happens when they make a transfer, they have a sense of what's happening with that caller with the other agency. And this isn't just internal policies and protocols, but also we heard that things like memoranda of understanding, MOUs signed by various partner agencies were a really important way to formalize those roles for everyone. Next slide. In Orange County, as you'll hear more about, 988 and 911 are co-located, and we heard how that really helped with building rapport and trust between agencies and allows for a more kind of informal support in addition to the formal support that is is possible through the formal interoperability protocols. Next slide. People also talk to us about kind of the general attitude at each site towards serving the public and making sure everyone gets the appropriate level and type of care, keeping people in the community when possible for treatment. People didn't have to be convinced that interoperability was important often because there was already a certain level of buy-in at these sites. Next slide. Cross-training opportunities. So cross-training was valuable because it helped to dispel myths and answer questions about the role of each agency and how they handle calls. For example, they would have 988 call center staff and PSAP staff come together to do their trainings. And this helped everyone kind of meet each other, which sometimes putting face to a name or a person on the other end of the line itself is really valuable, but it also helped everyone feel more aware of how calls are being handled once they get transferred over and what the capabilities are and what the resources are. Next slide. Something unique about Fairfax County is that interoperability was required through state legislation. And as a result, there were state level resources like planning guides and frameworks that were provided to help to guide the planning process. And that was seen as a really useful starting point for planning and kind of pushed them as to where they had to develop common language. Next slide. The last one that I'll highlight here is the presence of an implementation champion. Now, this is not a term that anyone said when we interviewed them, but an implementation champion is someone who promotes and is really enthusiastic about implementing the innovation. And after doing our interviews with this, it was clear that each site had like the one or two people who had really led the charge and led the planning and been the force behind implementation. It was different people at different sites. Sometimes it was 988 leadership or PSAP leadership, or one place it was a project manager who didn't come from public safety or clinical service backgrounds. So it's not that there's a particular discipline that's a more effective implementation champion, but rather just having one or two people who are really leading the charge made a difference. Next slide. So those are some of the key factors that sites said influenced the success of their interoperability plans. But as I mentioned earlier, I also wanted to talk through some of the barriers. And I think that these are things that are probably going to feel familiar to many of you who might be in the planning or implementation process. So I want to not just highlight the barriers, but also some strategies that have been found effective by these sites. Next slide. So when you begin planning for interoperability, one of the first things that you'll know is that there are a lot of different partners to engage. PSAP, 988, local hotlines, law enforcement, mobile crisis, behavioral health, peer support. And the number can be really large. So how do you approach this? I think one of the most important things we heard is there has to be sufficient lead time for planning. A year, 15 months, 18 months. This doesn't happen overnight. And there has to be a regular cadence of meetings, whether it's weekly or biweekly. We learned that it is really important to bring all of the agencies together sometimes. Like you do have to have everyone in the room at some points because this is a multi-agency response. That also helps to make sure that everyone is brought in. At the same time, we also heard that sometimes it's valuable to have kind of breakouts of certain subgroups of people. For example, in Fairfax, they had separate sessions. They call them synergy sessions, specifically between PSAP and 988 to talk about the call transfer in a more narrow way. And then in their large group meetings, they talked about how it plugged into the continuum of care. And we also had people say, it can't just be agency leadership. It has to be people who are currently working on the ground or have experience working on the ground. Next slide. As you plan, there are a lot of definitions and decision points that have to be decided together, but one of the most important and potentially most difficult is how to define risk. So all of these different decision points do require decisions about risk. What's the risk that a person will harm themselves or harm another person? And what's a tolerable level of risk? When you bring so many disciplines to the table, you have to be ready for different disciplines to define risk differently and have different levels of risk tolerance. For example, public safety versus crisis call takers. And then it's not just those cultural differences. It's also things like issues of personal safety, people being concerned about their licenses, professional standards, the concern about liability. What happens if something goes differently than expected and someone does end up hurt? So getting all of this out in the open is important, but you also then have to have a way to move to shared decision-making and common language. So one strategy that people told us was effective was talking through specific case examples and having each agency say how they would handle that, and then figuring out under this new system that's being built what they see as the ideal shared way to handle the situation. And a common language is a part of that. People from different disciplines might all use the term risk, but it might mean something really different. And so it's about not making those assumptions, but making sure all of that is really explicit in the room and then developing a common language. Next slide. So I alluded to the issue of liability concerns. This is something that people are very concerned about, and in our interviews at least was most often raised by PSAP call takers and leadership in particular. What happens if they transfer a call to 988 and then someone does end up hurt? PSAP call takers said it's not just liability, it's that they feel ownership over calls, and so they worry about what happens. They want to make sure that that person is in good hands. So there are some things that can be done to help with this. Having structured protocols that guide the decision is really valuable, because when there's less subjectivity in the decision-making process, then call takers don't have to defend their individual decision. Rather, they can point to the fact that they followed a structured protocol that led to a certain response. Some call takers also told us that it was helpful when they could override a decision to just transfer to 988 and also ask the person if they were comfortable with law enforcement being sent out if there was a situation in which they felt pause, especially early on in implementation. And then formalizing those procedures as much as possible in MOUs or MOAs. Cross-training is something that can also help with these liability concerns, just so that people are aware of how things are handled by the agency they're transferring to. And then sometimes if specific concerns persist, there's a need to dig into the data. In Sioux Falls, they told us that they were especially concerned about cases that get transferred from 911 to 988, but then get transferred back to 911 because the PSAP call takers feel like they've lost precious minutes by doing the transfer. So they dug into the data about it, and they found that this doesn't happen very often. And so this was something that was looming large in people's minds as a concern, but actually happens very little. And they examine each of those cases to make sure that if there was something that could be handled differently, that there's training provided. Next slide. So I also touched on the issue of different agency cultures, and it's not just about these disciplinary differences, it's things like pace of work and work hours and the way people cope with difficult situations. And this can create tension in a working relationship. So strategies that are effective for this are creating as many opportunities for kind of informal and formal communication as possible. Cross-training is an example of a formal opportunity. We also heard that sometimes people will give a call to the opposite call center to find out how a case resolved if there's a lull, just because that also allows them to make a connection across agencies. But it's also these less formal things, like in Orange County, we did hear about, because they're all sharing a space, they also share meals and they celebrate holidays together. They provided 988 call takers the same uniform as PSAP staff, and those types of things help to bridge a cultural divide too. Next slide. We know a lot of people struggle with issues related to data sensitivity on both sides. Behavioral health related data, but also sensitive criminal justice data. And so as you're planning, there are a lot of questions that have to be asked. What data must be shared, in what format, for what purpose? And when I say for what purpose, it's things like what is needed for the actual call transfer decision, what is needed for quality assessment and training, what is needed for evaluation, maybe what is needed to fulfill state reporting requirements, and then figure out who needs to see what aspects of the data. People told us that you really need to loop in your attorneys early on in these conversations, because they are going to have an important stake and also help you to navigate how the influence of things like HIPAA might make a difference. And we learned that there are sometimes formal ways that you can build in sharing into a data system. For example, in Orange County, two call centers do use the same CAD system, and they figured out ways to kind of silo off the data so people only see the sensitive things that their piece of it needs. In Sioux Falls, they don't share a data system, but we learned that they Sioux Falls Police Department developed kind of an outcome reporting form that they can share with their 988 call center so that they at least get a sense of how these in-person responses are resolving. So there are some options there. And next slide. And then finally, it's important not to overlook the need to update infrastructure, and in particular, infrastructure related to the telephone side and the CAD side. So for the telephone side, it is things like programming single button transfer capabilities. That way, PSAPs don't have to be dialing 988 and going through the introductory components. 988 call center staff know calls come from 911. But also updates to the CAD system. So this is customizing parts of the EMD protocols. If 988 or a local hotline is going to use the CAD system, figuring out how you customize it to serve their needs. In Fairfax, they had to update their CAD system to capture this like 4-level state triage framework that was being implemented. And so knowing that there's going to be a need to create those changes to systems, and also thinking through how you can leverage that data for something like quality assurance or evaluation. Next slide. Okay, I am going to wrap up in 1 minute. Next slide. I just wanted to emphasize here kind of the cross-site takeaways that we saw as kind of the biggest picture things that a site could maybe think about if they're just starting the planning process. It's about collaboration. It's about policies and procedures, but also knowing that interoperability is a lot more than just a call transfer. It's also the whole continuum of care and how you get them engaged. But also knowing that you can rely on existing tools, this report, but also things like that playbook by the National Association of State Mental Health Program Directors. And I'll just conclude with one final slide about the benefits of interoperability, which I probably don't have to convince this audience of, but people just told us again and again how they really valued how it created a no wrong door approach in their community to getting people with the right type of service. And on just one last slide, I really enjoyed this quote that we had from a stakeholder. Our agendas look a little different, but at the end of the day, it's all about serving the person in front of us. So with that, I will wrap up, and I'm so thrilled to pass it over to my colleagues and partners in Orange County.
Good afternoon, everyone. Darcy Miller, Commissioner of the Orange County Department of Mental Health and Social Services, and
Hi, everyone. Lacey Trimble. I'm the Deputy Commissioner for the Department of Mental Health in Orange County.
what a pleasure to hear Stephanie, Dr. Holliday, give the report out of the amazing research project that she and her team conducted. We in Orange County were very proud to be part of that research, and to see it all laid out for all of you to use going forward is really rewarding. A lot of work went into making this happen here in Orange County, and I'm excited just to give you a few minutes and help you to understand, what framework was laid to get us to a place where this was even possible. So next slide, please. So we are a SAMHSA graduated Children's Mental Health Initiative community, and as that funding went out, so much is about sustainability and how you move forward with the values and principles that you really targeted for the 6 years under that funding. And we move forward with expanding the messaging to a comprehensive continuous integrated system of care, which is a model developed by Drs. Minkoff and Klein. And with it, we brought a large cross-system, multidisciplinary stakeholder group together of about 150 members of our community to really develop a shared vision, a shared mission, and some values that were important to us, acknowledging that we are in the hope business, that we have a responsibility of creating a no wrong door approach, and that we wanted people who needed services, whether you came to get a SNAP food stamp benefit, or you came for mental health, or you walked through the criminal justice door, that we were together assessing and supporting you in the best way to help you realize your dreams, that was the most respectful, strength-based, easy access, compassionate with empathetic response, and culturally linguistically responsive. So appreciate all those stakeholders that helped to lay that groundwork. That was about 12 years ago. We continue to have regular steering committee meetings, change agent meetings. We do, everyone new who comes into our system of care does a 4-hour orientation targeting these values and messaging them. Next slide, please. So where we started with the beginning of laying the groundwork for the redesign of our crisis continuum, and you'll see how this impacts the 911, 988, 311 interoperability. So we had at one point a 24/7 mobile response team. They were run by one of our contracted agencies in the community, had been in place now for 4 decades here in Orange County. Started with one person, one team, and expanded to a much larger operation to address our county. We had a 24/7 helpline that was run by another agency that was run by volunteers. They had their cell phones at home. They answered those calls. They transferred them as they needed, whether it was to the 1-800 mobile response number, maybe sometimes to 911. We have peer services that were provided by a third entity that involved in our hospital, involved in peer diversion for those who come out of the hospital. We had a 211, which did referral, resource and referral, and some counseling support that then referred back to one of these other options. And then we had our substance abuse education agency that had a call line for people who had substance abuse challenges. And so lots of numbers to call. Next slide. Through many of our meetings, through both the comprehensive continuous integrated system of care and other initiatives we were moving forward, it became very clear that our residents and law enforcement, they didn't know who to call at the right time. The mobile response was mostly responding only to individuals with mental health needs because that's where the funding came in. So that was their task. We had multiple agencies supporting a single individual without knowing what the other was doing. We needed to create accountability and expectation for those who were in crisis, and we need to follow up. We need to be sure that someone we met with today, they were still okay tomorrow. So, and we also need to align our services with the crisis intervention benefit guidance for Medicaid managed care organizations and providers. And we wanted to answer our own lifeline calls. So before we got started on this redesign, our 988 calls were being answered by another county, and we wanted to bring that into our own home community. Next slide. The opioid epidemic and the impact. So we did a 5-day stakeholder mapping process. You heard Lacey's a green belt and Lean Six Sigma. I'm also green belt and Lean Six Sigma. We feel strongly that you need to do the mapping. The problems are really not about people, they're about process. We brought in an expert, Dr. Corey Waller, to help us walk through that in our community. We did sequential intercept mapping with the Justice Mental Health Collaborative that was offered by our State Office of Mental Health. And at the end of the day, the message became very clear, especially from our law enforcement. We have 32 police departments across Orange County, and they said, please give us one number. Give us one number to call. Help us to make this simple for the people we're trying to support the community. Next slide, please. So why not a stabilization center? This is a whole, there's a lot of push for stabilization centers, and I support stabilization centers. We're a geographically large county. We have 32 police departments. We already had some pieces of a stabilization center together. We had 2 behavioral health urgent cares, and there's a great cost and a great staffing challenge to really bring a stabilization center up and running to replace, for example, your emergency rooms and what their behavioral health response is. So we really created or expanded our stabilization center without walls here in Orange County. Next slide, please. This is our original process map, and I won't go through details of the process map. I believe you will all have access to our slides and can look at them more closely. Next slide, please. The work to get this done. So for us, we're the Department of Mental Health, and we have a responsibility to have services in place for both individuals across mental health, developmental disability, and substance use, and their families. And to do that, we do some work directly, but we do have a lot of contracts in place some state dollars, some local dollars, some federal dollars, a whole mix of funding that helps them move things forward. But we took 3 agencies, they were all working separately. We said, we need you to come together. We need you to collapse your call lines. We need to have a single call line here in Orange County. We need to professionalize it so that we can take our own lifeline calls. And we need you all to be communicating across this continuum. So each of you knows how you're supporting that individual and family times all those individuals and families you support. And that was weekly meetings for a year to get ourselves to that place, and really appreciate everyone who was willing to give up a little bit of turf, to really change some of what they were doing, to have a collective understanding of why we were making this difference. And then once we had that group together, wow, can you imagine if we co-located with our emergency operations center and we were able to be part of our 911 call center and the great work that they do out of our emergency operations center. So approached our county executive, Steve Newhouse, with this idea. And he said, you know what, let's go, let's try. We met with our commissioner of emergency operations center. He and his team agreed. They not only agreed, but they have been amazing champions in helping us move this forward. Not only did they have to deal with another county department, but 3 separate community agencies that are contract with another department to be co-located within their emergency operations center to make this happen. Next slide, please. So let me just talk about the 311 for a minute. So we all agreed, you know, great, we have a 10-digit phone number people can call, but who can remember that? And how do you give it to the person who's homeless on the street when they're not going to be able to remember it? So we came up with 311, and within minutes, the federal government announced 988. And I have to tell you, we probably would have done all the work it took us to get to having a 311 call line if we knew that was coming, because it's such a stigma reducing, access positive ability to have people call 988. And we really appreciate, and we publicize both 988 and 311 in this county. And I will tell you again, that wouldn't have happened without our emergency operations center partners who did all the work to make that happen for our call center. But some of the challenges, Stephanie did a great job of talking about those challenges, and really what we have here, establishing roles, relinquishing territory, mutual accountability, legal issues such as, you know, the MOUs, the BAAs, the mutual indemnification clauses, you know, billing and how that happens. All of that needs to be sorted out, and it takes a lot of communication to make that happen, and a willingness for a lot of give and take. Next slide. This is our new updated process map. We began this new updated process map in 2019, and we've added to it since. You know, we have our crisis intervention training for our law enforcement out of our police academy. Every new recruit comes through, that includes crisis intervention training, the 40-hour training, and we have senior officers across the county who have been trained previously and who will be trained going forward. Formal processes in place where they do the intervention either solo because a call came in to them directly, and or with their mobile response team. They then send their report back through our call center, and they do follow up with those individuals who receive services and support, along with all the rest of our continuum. I'm going to move fast because our time is going quickly. Next slide. The 911 interoperability went into place in 2023. We were able, 988 311 was able to turn calls back over to 911 since they sit on the floor together. They share the same CAD as has already been mentioned. They communicate, they cross-train, they share meals together, they get to know each other. They also know when someone is in crisis and needs immediate response. And our 988 call center could turn calls back over to the 911 in 2021 and 2022. In 23, we were able to establish where we could transfer calls back and forth. And that had to do with policy that was already in place with our 911. The agreements that were in place that said their 911 calls would go to fire, police, and or ambulance. So we needed to get our call center added to that so that it could be an option for them And this flow chart takes you through what happens. I won't go through detail of it, but it's really about mutual respect. It's about being able to case review. It's about working through issues. It's about regular meetings. We still meet, our leadership at the Department of Mental Health meets with our 3 contract agencies every week for an hour to go over process, to go over high acuity cases, to address any issues we might have with the co-location, and really that communication is what helps us to continue to be successful. Next slide, please. This just shows you how we're funded, a combination of state, county, and revenue funds that help to put this system in place. It costs us nearly $3 million to operate the contract portion of our programming. All of the Emergency Operations Center space and collaboration is all county funded, as well as our Department of Mental Health, and that is in kind for this continuum. Next slide, please. This is our crisis continuum today. I have to smile because our call takers were literally using cell phones, using little back offices where they were receiving calls. To have this level of sophistication and support and really truly respect the caller and the ability to provide them comprehensive care across this continuum it just makes me smile. Next slide. We have consistent messaging across our community. As I said, our crisis call center at one point only took calls for people who were in mental health crisis and or who had suicidal ideation. Now we accept calls for people who have mental health, substance use, developmental disabilities, rental assistance programming. We went live in 2019, right before the pandemic really hit its peak. And what a great resource that was for our community. So next slide, please. And I am going to turn this over to Lacey to cover the next 2 slides.
So one of the major benefits to sharing space and sharing equipment is that we would not have had access to the technology that we have by using the CAD system, by having the ability to send calls back and forth. We're using the computer-aided dispatch system. So we are able to prioritize and record our calls in real time and identify status, location of the responders in the field and dispatch people very quickly. And it's really a credit to our Emergency Operations Center that they allowed us to use their licenses. We purchased our own systems, which you're seeing a picture of a training room now, but they have 6 monitors. They have 1 for just email and everything else is related to the CAD. The other 5 monitors are maps and calls coming in and the ability to see what's going on the floor. So the technology has been an amazing benefit for us. Next slide, please. This is just an example of the data that we receive when we meet with our call center weekly. This is how it goes into the CAD. They have a primary problem type, and then they have 48 different dispositions that are connected to those problem types. So somebody might come in as a 911 diversion, but also need help with food security, homelessness, a number of things. And we can track how many calls of each type and make sure that people are getting their needs met. Next slide, please. This is showing the progression of the number of calls that we've received over time. We opened in April of 2019 with our co-location, received 16,000 calls that year. And in this year, we're projecting to exceed 56,000 calls. That does include people calling us and us doing follow-up. So it's not just people reaching out to us, but I think something very important about our continuum is that we have an expectation for follow-up to ensure that the needs are met, whether they had a mobile response intervention, whether it was a call that was transferred from 911 or somebody just called for assistance connecting to a resource. We want to make sure that those needs are met so that they don't go into crisis and end up with unnecessary hospitalizations or connections with law enforcement. Next slide, please. Really exciting for us on the technology side is the access to the Rover application. So the 911 center was using this as part of their dispatch and was kind enough to share with our teams this technology. So we're able to see in real time where our teams are, what their expected ETA is to a location. It really helps with safety, but also being able to say to someone, somebody's not going to be able to be here right now, but we think they'll be able to get to your location in the next hour. Because we don't have the resources to have a team immediately respond to all. It helps us with triage and it helps us make sure that our teams are all safe. Next slide, please. Darcy, did you want to go back to these slides?
Sure. So our mobile response team, what we already talked about, was established in 1991. It was available 24/7. We are able to stabilize, divert hospitalization of the number of interventions that we do in a month. So they do 400 interventions in a month. Only about 15 of them result in involuntary transfer to the emergency room. They're doing an excellent job of stabilizing people in the community. Police are not having to respond to calls where community safety is not a part of the issue. And it's really makes a difference in everyone being able to specialize in their area. The mobile responders come to your home in unmarked cars. They come there with an intention of providing you support and access to services. And they will include and co-respond with law enforcement, which they've done for 4 decades. When there's a known history of potential violence, when there's a concern about guns or other threat in the area, but otherwise they are responding solely as behavioral health providers. Next slide, please. Our peer diversion. So we've had peer specialists. There's a lot of talk in our community, in our country, really, about the role of peers, the lived experience that they bring, the dynamic of connection and engagement that they're able to enhance with the professional response is incredible. We had a group of from a National Guard with one of our local hospitals and one of our peer providers who helped to create, and obviously PeerRx, to create this technology that allows our hospitals, our call center, to put in a request for a peer support. So somebody showed up in an emergency room and they've had an overdose and they could benefit from peer support. The hospital can request a peer to respond that will go out to all the peers. Whoever's geographically closest and available and meets the criteria of the request can respond to the location of that individual immediately. And they have found that response time is as little as 20 minutes to go in and support, to wrap around services, to encourage them to engage in treatment. It's really been a nice addition to our continuum of care, and appreciate all the work that went into making that happen and the peers that help to save lives every day. Next slide. We also have a text for teen line that is part of our crisis continuum. And that is available 24/7 in this redesigned model. Really a benefit for our young people who communicate in different ways than what we have been accustomed to. Next slide. This is about our CIT response, which I already mentioned earlier. Law enforcement appreciates that Mr. Jones, who they've been out to see 3 times, that once they send that CIT report in, turn it back into our continuum, we are following up and responding. Typically each week, our peer advocates give us a story of a success, and so often it involves someone who's connected with the CIT, and that they have been able to get someone housed and in treatment and connected to services. It's really powerful. Next slide. This is our overdose response. Just takes you through the flow chart of how our overdose response team works. So the police departments respond to an overdose call. They submit the incident into our HVCAC. That report goes to our Orange County Crisis Call Center and to our Department of Mental Health. And then we determine what the best follow-up is, and a peer specialist goes out within 24 to 48 hours with a care package, engagement, connecting them. And it also can flow the other way from our Orange County call center that takes you back through the flow chart to get those supports.
And I'm just going to offer Commissioner Miller to take over because I know you have another commitment that you're a few minutes late for.
Thank you so much. It's been a pleasure to be here with all of you today, and I appreciate you, Lacey, for recognizing that. Take good care.
Next slide, please. So this is just an example of the peer support package that we send out with the overdose response team. It includes Narcan kits and other harm reduction supplies, information on connection to resources. And it all goes through the call center, but it's been really powerful in the stories that come back to us of the individuals who have saved their loved ones with access to this and the training that we provide on how to use the Narcan. So been a huge benefit to our system to have this go out through the call center, through our peer support team. Next slide, please. So some of the lessons learned is that it really does take time. The redesign process was not always easy. It was sometimes messy. It takes ongoing monitoring and conversation, but it does make a big difference in the long term for the people we serve, to make sure that we are all accountable to each other, that we are making sure people are connected to resources, and that there's follow through for those individuals, and that we don't just hand them a phone number, we help them make the call when needed. We started before we knew 988 was coming out, and the 3-digit dialing code has made a huge difference. It's easier for marketing. It's easier for our law enforcement partners. It's made it possible for them to have a single card to hand out and be able to connect to any variety of resources. It doesn't matter if somebody needs mental health, behavioral health, OPWDD services, and developmental disabilities, substance use. They can be connected to all of them through our call center. It did take time to delineate all the different roles and responsibilities. It helps us to avoid conflict, to make sure that we are not stepping on each other's toes, and it makes sure that everybody is working efficiently, because there is so much need that we want to make sure that we're reaching everybody. Having 3 different agencies has been so beneficial to us. It's been a way to have more accountability. It was challenging in the beginning, but we are able to call each other out when something might be missed. We're able to partner with each other when there is a particularly complex need and we need a variety of resources. Sometimes we team up and have multiple agencies that's responding at the same time, because they're not, for example, letting our mobile response team in the door, but our peer can get in the door and then get the mobile response team in if we need, and vice versa. I think one of the things we're most proud of is our co-location with emergency services. It saves on costs. It allows us access to different levels of technology. It would be much more difficult for us to have had a 24/7 professional operation like this without that partnership. So we're very grateful to that. Next slide, please. And that is all we have for our slide deck. So I guess we go into the office hours.